Hi, good evening. Welcome to the MyCP webinar series. My name is Paul Gross, and I will be your host for this evening. I'm the president and CEO of the CP Research Network, and I'm really excited to have Dr. Rich Stevenson here to talk about this topic of growing up well with CP and the importance of nutrition to health and well-being. The agenda is going to be, we're going to talk briefly about the CP Research Network. For those of you who attend our webinars, this will not be news to you. And then I'll turn it over to Dr. Stevenson, who's going to leave a good chunk of time for Q&A and discussion. He's in particular got some discussions for you that I think that will be very engaging. So the CP Research Network's mission is to optimize the lifelong health and wellness of people with cerebral palsy and their families. And we do that through high quality research, education, and community programs. Just to give you a little bit of a sense of the network, which was founded in 2015, the first thing, our first focus was on education, and we launched the CP Toolkit, which has served more than 5,000 people to date. We released a Wellbeing guide and then went on to translate the toolkit into Spanish and Portuguese. And then in 2020, we launched MyCP and enabled personalization so that you could take this sort of wealth of information that we provide on our website and get very specific recommendations based on your experience with CP, either as an adult or as a caregiver of a child with CP or caregiver of an adult with CP. Our research focus is the largest effort that we make, and the first thing we were founded to do was to create a clinical registry or a database of people and characteristics of people with CP. We launched that in March of 2016, and it's now got more than 8,000 people in it. And then we launched a community registry that's really aimed at also a database of people, but capturing information not that's covered in the hospital, but about people's lived experience out in the community, and we have about 2,300 people in that. One of the first things we did was a program we called Research CP to set a patient-centered research agenda, which was published in 2018 and really guides our work. We went on to get significant funding milestones from the National Institutes of Health for our genetic causes of CP, got many other grant applications in currently, and then we have a partnership with the largest private funder of CP research, the CP Alliance Research Foundation. We're quite busy in developing research. We have 29 concepts that are currently under development or in application to get funding or currently executing, 4 of which are quality improvement initiatives. Quality improvement's another way to improve outcomes that gets results much more quickly. We started those in 2020. We've had 10 academic publications in journals, over 39 academic presentations, and we have more than 5 manuscripts under development, so there'll be a lot more publication coming in the coming year. And then on the wellness front, we've partnered with the National Center for Health, Physical Activity, and Disability for the Mentor program, and I see that some of you that are here tonight have participated in that. For the other adults, I would really recommend it highly. So we are a 501c3 that brings together all these groups of people to try to improve outcomes. We physically have a data coordinating center that's hosted at the University of Pittsburgh, and that houses our clinical and community registries. And then the rest of the entity's work is its education and well-being programs. So MyCP, which I mentioned, is a free personalized web portal that is inside of the CP Research Network, and it really involves the extended community. For community members, it allows participation in the community registry through surveys. It also is a place where we discuss research and research priorities. We personalize your web resources and give you access to our free education programs. If you're not a MyCP member, it is free. I'd recommend that you go to mycp.org and sign up. So registries, I said, are databases that capture characteristics of people with CP. One of the most important data points is the Gross Motor Function Classification System, or GMFCS, which classifies people into 5 levels based on how they move through the community. And here you can see from a snapshot of 5,200 patients back in 2021, the curve of distribution of people across levels 1s, 2, and 3s ambulate independently or with an assistive device, and 4s and 5s ambulate use a wheelchair to get around the community. And then if you look at the age distribution, where we have these age bars, you see that the clinical registry leans towards children, but more than 20% of the people involved in the registry are adults in the clinical registry. If you compare this to the data that we collect for the same 2 data points in the community registry, this is with a smaller n than the n that I quoted, but from February, you see the distribution is quite different. And this reflects whereas the clinical registry has a bias of people that go into the hospital, this has a bias of people that are looking to be involved in things with CP out on the web and social media, and it leans more heavily towards people that are GMFCS level 2, so more heavily towards ambulators. And then you look at the age distribution, and you see you have a lot more adults involved in the community registry than we do in our clinical registry. So those are our programs, a little picture of us when we were gathered in Michigan in 2019 to work on our research. We've got our health and well-being programs. We focus a lot on community engagement, and that's the group in the bottom right that met for Research CP in Chicago in 2017, and then our educational programs. We are spread across the country. We're 30 centers and growing. The green pins are sites that are actively collecting data into the registry. The yellow pins are working on the sort of technology for the way we collect that. Red pins are working on compliance and sort of getting onboarded. And the blue pins are sites that have raised their hand, said they're interested, but they have not found the resources to join the network. And then again, the green circles are for the sites that actually do lifespan care. So I'm really excited to turn it over to Dr. Rich Stevenson, who's a developmental pediatrician and a professor at the University of Virginia. He's the head of neurodevelopmental and behavioral pediatrics. He's a past president of the American Academy for Cerebral Palsy and Developmental Medicine, which is the big academic society that focuses clinicians and therapists on CP. I think he recently stepped down from a role running the Institutional Review Board, which governs all the human subjects research that happened at UVA. And he is the principal investigator of our work in nutrition in the CP Research Network. And he's also very actively involved in some of our committees focused on education and our standard operating procedures. That's what SOP is. So with that, I turn it over to Dr. Stevenson.
Right. Thanks for that nice introduction. I appreciate that, Paul. Good evening, everyone. I'm sharing my screen here, hoping that you can see my slides now.
We can.
Put this thing out of the way. Okay. Well, glad to be here to talk about nutrition, health, and well-being. The title of talk's gone back and forth over things, over different wording, but I do like thinking about it in terms of growing up well. And while I'm going to be focusing my comments on work done with children, I feel like it has a lot of implications for growing up and adulthood. And so I will welcome some conversation about that. I do have two quick disclosures. I did edit a book with Laurie Glader geared towards primary care providers. I'm not going to really talk about the book, but a lot of the pictures that are through the talk are from the book, taken with permission, of course. And I am going to present some preliminary data that has not yet been peer-reviewed and published. So take it with a grain of salt. Okay. What I'd like to accomplish is to talk about growth differences in CP and the relationship of those growth differences to nutrition, physical activity, health, and well-being. I want to describe some challenges regarding assessment of growth and nutrition in children with CP. And by assessment, I mean both the measurements themselves and then how one interprets those measurements. And then I'm briefly going to describe some ongoing research projects within CPRN and some projects that we're looking forward to in the near future. Two of my collaborators from Nationwide, Praveen Gade, Dr. Gade, Praveen Gade, and Dr. Judy April Marai are also on the on this webinar, and I'm sure they'd be happy to chip in some conversation as we get into that part of things. And then in the end, I really want to promote some discussion about how we might build clinical and research programs around diet and physical activity to improve health and well-being through childhood and into adulthood. So we've already had a quick introduction of GMFCS levels. I put this up here just to make sure we're all on the same page about what these levels represent. I like to show this to give us some gauge of how common different levels are. Now, this is data from the Australian Cerebral Palsy Registry, which is a population-based registry. The United States doesn't have this type of registry that's collected in sort of basically trying to collect either a random sample or all individuals with cerebral palsy across the country. But this shows you the breakdown of what most population-based registries do show, which is that levels 1 and 2 make up about 60%, and levels 4 and 5 about 30%, and level 3 is generally one of the lowest percentages, about 12%. A lot of work, the level 3s get lumped one way or the other, either with the level 4s and 5s as being the more severe end of the spectrum, or lumped together with the 1s and 2s as being ambulatory. And I think the relevant thing is here that if you look at all the ambulatory individuals, it's 70% or a little over 2/3, and those that are non-ambulatory about 29%. And most of the research has been done on the more severe end of the spectrum. And a lot of the research I talk about today is with levels 3, 4s, and 5s. Not because it's more important, but simply because that has been what has been studied. And I'd like to open up, I'll mention some things that include levels 1, 2, and 3 for sure. And so I would welcome comments about that. There's some aspects of studying that group which are just different. So let's start just by jumping in with growth charts, because this is where things begin in pediatrics. So the measurement of growth of children and the comparison of those obtained values to reference data are the fundamental aspects of health surveillance. Anybody who's ever taken their child with CP to the pediatrician, one of the first things that gets done. And often that's where worries start, because often kids with CP don't really fit well on those growth charts. The rationale for what we do here, the presumption is that good growth is equal to good health. Of course, the real question is how good does growth have to be in order for health to be good? I think sometimes these charts are a little bit misinterpreted by pediatricians, in fact, and sometimes this can impact on the way that kids are managed. So on this growth chart, for example, I have a couple of different colored dots. This is a growth chart for kids from birth to 36 months. And the question is whether somebody at the 90th percentile, this green dot, is necessarily healthier than somebody with the blue dot is at the 5th percentile, or even is it somebody at the 5th percentile in better health than somebody at the 3rd percentile, the purple dot. What exactly is ideal? Well, in fact, ideal, which is, pediatricians talk about ideal body weight, and the implication is that it's ideal for health, but there's very little information to guide what is the healthiest weight for any individual. These CDC charts, which are nationally representative in the United States, did not have any exclusions for health or SES. They did exclude very low birth weight babies, which might include a lot of kids who have CP. But in fact, there's very little data that links any point on these growth charts to health. And so the intended use of these growth charts is really not, it's not the whole thing. So in other words, information for evaluating the size and growth status is not the sole diagnostic instrument for evaluating growth. It doesn't begin and end with the growth charts. It is the beginning and gives you a bit of data, but clinical judgment is what's needed to judge whether or not a particular point is healthy for an individual child. And the real question is whether or not the general population growth charts are really appropriate for all children, and in particular for special populations of children, which I would submit includes cerebral palsy. It has been pretty widely accepted that Down syndrome, Cornelia de Lange, and some other unusual genetic syndromes are best judged by their own growth charts. But this has not become widely accepted in CP. And perhaps we should reconsider that. So I'm going to talk now about a little bit of information about growth in CP in terms of what we know. This chart shows one of the earliest charts that were made for kids with CP. There are two iterations of CP growth charts which were developed in California. The first one was published in 2007, and then the revisions were published in 2010. And this gives you, and these growth charts were developed specifically related to each of the GMFCS levels. And this shows in the dark lines with the pink labeling what the 10th, 50th, and 90th percentile of children with cerebral palsy who were group 5, which later got renamed to GMFCS 5, compared to the general population, which is superimposed on this slide and highlighted in green. So children with CP typically have different pattern of growth compared to the usual growth charts, and this growth difference is severity dependent. This chart actually illustrates this a little bit better. This is just looking at weight, and in the shaded region, this shows the 10th, 50th, and 90th percentile shaded in a color of orange, and then superimposed on it is the 10th, 50th, and 90th percentile for children with CP. And in each of the panels, you have a different level of GMFCS from 1, 1, 2, 3, 4, 5 in the bottom center, and then 5 with G-tubes. So 5 without G-tubes and with G-tubes. And you can see the progression over time. In GMFCS1, the average growth is about the same as the general population. The 50th percentile is not very different, but the 10th percentile and the 90th percentile are quite different in terms of showing a greater variability. So there are some kids with GMFCS1 that are much smaller than the general population, and some kids that are heavier. GMFCS2 shows a little bit more of a drift of the 50th percentile downward, and the 10th percentile significantly downward, although the 90th percentile is about the same. And all of these are in girls, by the way. GMFCS3, a little bit further down, so that the 50th percentile for CP matches up with the 10th percentile of the general population. And you can see the progression with severity of functional mobility, such that GMFCS5, the population of children with CP hardly have any overlap, at least by the time you get to be 12 years old, with the general population. And the same slides with boys shows exactly the same pattern. So I became interested quite a few years ago to study growth, and I developed a group called the North American Growth and CP Project. We did our work mostly between 1996 and 2006, focusing on children who were GMFCS levels 3s, 4s, and 5s. And our initial goal was to develop growth charts, but that ended up being kind of complicated, and we decided not to do that. And so we studied a few other things. And to summarize work that we did, just to illustrate some of the differences that we discovered. And some of these are pretty self-evident if you've been around individuals with CP. So children with CP are shorter, lighter, and thinner than the typical population. Nutritional factors certainly play a role in this different growth that kids with CP illustrate. But it's not all nutrition. And there are non-nutritional factors that are severity dependent that also play a role. Exactly what those non-nutritional factors are not very clear. There are some children with CP, which have been shown in a number of very small studies, that are growth hormone deficient, and that probably plays a role in their growth. In addition, this has a significant impact on bone, and children grow because their bones grow, in a sense, and so children with CP have severity dependent decreases in bone mineral density, and that can sometimes lead to fractures. The linear growth velocity in children with CP is low, so that means they grow more slowly than the typical population, and over time their growth falls further from the norm with age, and that's independent of nutrition. And finally, we showed that low body fat was associated with poor health and poor social participation. So nutrition matters, growth matters, but more needed to be discovered. And one of the challenges we sort of set to work on is how to measure children who were in effect unmeasurable. How do you measure this child? So in terms of getting a height, this is a child that because of her cerebral palsy cannot stand and cannot even lie straight because of joint contractures and scoliosis. So we worked on finding alternative ways to measure kids to see whether or not kids could be measured and described in a new way. So one of the things that we started using are segments, segmental lengths, specifically tibial length and knee height. And this shows one of the measurements that we use. And in fact, there are formulas that we developed that estimate how tall somebody is by measuring this tibial length. That technique is pretty good at the population level. That is, when you want to look at a group of kids and see how they're growing overall, it's a useful way to do it, and you can make this calculation and estimate how tall they are. But at the individual level, it's not very good for decision making. So in other words, some people have short legs and other people have long legs. And so in any individual child, you don't know how good the formula is for estimating their height. And this is a fundamental problem with measuring growth in CP, is that measuring their height can be a challenge, number one. We did use, and we couldn't compare this tibial length with typical population because there were no US reference data. But this other measurement, which is knee height, does have some reference data. And this chart at the bottom, I'm sorry, my is acting up, does show that the kids with CP, which is the lower group of curves from the 10th to the 90th percentile, is significantly different from kids with the general population here. And just those kids who are level 3, 4s, and 5s, this just shows how different their growth is. Even in their body segments, they have shorter legs. In addition to those measurements to try to estimate height, we used other measurements to try to look at body fat in terms of how much extra fat kids have for health. And a couple of these measurements are mid-upper arm circumference and tricep skin fold. Now, another study that we did show just look at tibial length curves, and this study is done in levels 1, 2, and 3, which basically showed that this top line is the typical population, 1s and 2s are in the middle, and 3s are at the bottom. Again, this severity-specific decrease in linear growth. Then in 2010 came these growth charts. which looked just at weight. And the beauty of weight charts is that you can get a reliable weight measurement for almost everybody. This came from a study of 102,000 measurements on 25,000 children with CP, and then followed them from 1988 to 2002. It included 160,000 years of follow-up. And one of the things they were able to see is which of these children died over that time period. And there was a mortality rate of 9 deaths per 1,000 person years. And those kids who were below the 20th percentile had a significantly increased risk of death. And this increased with severity. And basically, children who were levels 3, 4s, and 5s who were below the 20th percentile of growth, and this is for the CP specific growth charts, not the general population, had an increased death rate over the next 3 years, and kids who were below the 5th percentile in 1s and 2s had a similar increase in rate. So in summary then, kids with CP are different. Measuring growth in CP can be difficult, and exactly why they grow that way is not well understood. The question is, what's the cutoff for health? How can we do that? These CP growth charts showed a link between the GMFCS stratified weight percentile and health as measured by risk of mortality. Well, we wanted to see whether we could replicate that study using our old data from NAGCEP. So what we decided to do was look at the link between that weight percentile, the 20th percentile, and health, but used a different marker of health, basically looking at healthcare utilization, how many times they've gone to the doctor unexpectedly, for example, and loss of usual social participation, and to see whether or not combining other measures of body composition like skin fold would strengthen that link. And we wanted to try to understand those kids who are at risk below the 20th percentile. And so we had 196 boys and 146 girls, GMFCS 3, 4s, and 5s. We measured, as I said, their weight, mid-arm circumference, tricep skin fold, and we looked at healthcare utilization. That is, how many days had they spent in bed in the 4 weeks before they were measured, how many visits to the doctor or emergency department that were unexpected, and then how many days had they lost in participation, days that the kids had missed school or their usual activities for child and family over the preceding 4 weeks. We measured that by questionnaire along with medical comorbidities and functional abilities. So the weight percentile was delivered from the CP growth charts, and then we looked at the relationship between the weight percentile with or without adding tricep skin fold and other markers. What we found is that, number one, the CP growth charts worked for our population. So this is the data from our NAGCEP work that was done before these CP growth charts were developed, and they fit pretty well for the girls, fits pretty well for the boys. And we did a statistical test, which just showed that they did fit quite well. And then we looked at how that weight, the percentile growth, how that related to healthcare use and participation. So what this shows, the center line means that there's no difference between a risk of any of these issues for those that were below the 20th percentile on the right versus those that were above the 20th percentile on the left. And what it shows is that those kids who were below the 20th percentile had a greater risk of having been in the hospital, missing their usual programs, and had greater total days missed of school and regular activities for both the child and the family. And then we compared those kids who were below the 20th percentile versus those above the 20th percentile to see how they were similar and how they were different. And what we showed that the differences were significant in terms of their body growth. Again, no surprise, but all measurements were significantly smaller. But they also had more severe feeding problems They also were more likely to have swallowing problems. They had gagging and vomiting problems. They had reflux and motility medication needs. And so those were the differences that we saw. And yet some of the similarities were surprising in that those kids were similar in terms of other medications they were using, whether they had seizures or not, whether they had orthopedic procedures or fractures, and their overall communication and vision and hearing. The severe feeding problems is simply a question that we asked families, and the answer to this was that it requires well-moistened foods or thickened fluids or required tube feedings. So basically, those kids that were below the 20th percentile, in addition to being small and thin, they also were more likely to have difficulty with eating and having more GI problems. And this just shows how much smaller they are than the rest of the population. This is the line where these measurements would cross over if they were the same. But you can see that those below the 20th percentile were smaller in every single measurement we could devise. Their heads were smaller, their arm circumference, their calf circumference, their upper arm length, their tibial length, their body fat in terms of triceps, their overall body fat. And then when you compared them to the typical population, again, they were very small. So these kids were small. And when you added, so you controlled for the weight percentile that they were at, and added having also being low in triceps, skin fold. So if they had their body fat measurement was low and had severe feeding problems, that basically showed even more that they were more likely to have been in the hospital, missed usual activities, and for participation. So our conclusion was that this provides some validation of the gender and severity match CP growth charts for these kids in levels 3, 4, and 5. Those kids below the 20th percentile associated with increased healthcare utilization and decreased participation, and then controlling for GMFCS gender and weight. This shows an additional association between markers of body composition and feeding symptoms. So these data suggest consideration of really using these CP growth charts more for comparison. And we feel warrant further research regarding the relationship between growth, nutrition, and overall health. But what about GMFCS 1 and 2s? Are healthcare utilization and participation the best outcomes for research? And what about other things like functional outcomes, activity level, pain and fatigue? And we'll come back to this, but I welcome your thoughts about some of that. Quickly, I wanted to show work from the Queensland Preschool Growth Study in CP. And this study had a group of kids across all levels of severity. That is kids GMFCS 1s, 2s, 3s, 4s, and 5s. We measured weight gain, linear growth, but also looked carefully at fat-free mass, lean mass, and body fat through kind of fancy state-of-the-art techniques. And we're also able to measure how much intake they took in, that is the calories they took in, and how much physical activity, how much they moved. And this group was pretty well nourished. They actually had excess body fat. And this was a study that compared them to typical population, basically their siblings and friends, and noted that this is true at all GMFCS level. That is, compared to typically developing peers, they had higher body fat and below average fat-free mass, meaning below average bone and muscle compared to typical children. And this was evident at a very young age. This was kids birth to 5. And BMI, which, if you've been to a pediatrician, they're often checking the BMI for children as a way to assess how much body fat they have. and BMI does a poor job of identifying at least excess body fat. And then the other thing that showed is that energy intake and fat-free mass, that for kids in GMFCS level 1, the higher the fat-free mass, that is the more muscle and bone, the more active they were in terms of measuring their activity. And that was, they actually wore something like a Fitbit so you could tell how much they moved. And it doesn't really distinguish which came first, the activity or the muscle, if you will. So they concluded that preschool kids with CP have altered body composition, extra body fat across the spectrum of functional capacity, and this difference is noted at a young age. All kids really had excellent nutrition, suggesting that maybe this excess body fat was partly iatrogenic. In other words, it was kind of created by people pushing kids to increase their body weight compared to typical growth charts. And they concluded that GMFCS1 habitual activity level was associated with better fat-free mass. So I'm going to just jump ahead here and get to the summary so that we have plenty of time for conversation. That is that children with CP grow differently. I hope I've didn't go through this too fast, and I hope I was able to explain it well. These fundamental motor differences, feeding problems, and activity limitations all seem to contribute to the differences in nutrition and growth. And that medical things kind of complicate the situation so that those kids with more medical problems are more likely to have problems with growth. And really our challenge is to figure out how we might ensure that kids with CP grow up healthy, happy, and strong. So, so we are moving forward to kind of carry this kind of research on. The collaborations I mentioned before between UVA and Nationwide in the context of CPRN, we're looking to further validate these growth charts and look at these weight percentiles and see if it predicts problems around surgery, you know, complications of surgery or more likelihood to be hospitalized. And we're looking to see whether or not the data that is already in the CPRN registry gives us more information in terms of linking some marker of growth with some marker of health. And we hope to potentially connect with even other networks so that we get a better understanding of growth over time. So with that, I will quit and see what you think. Where's the common ground for additional study? How can we improve our studies? I've become interested over the years in taking care of a lot of kids at the milder end of the spectrum about pain and fatigue, for example, and the role of pain and fatigue in limiting activity as kids CP and grow in age. What outcome measures should we be including? What are needed across the lifespan? So I would love ideas to see whether or not we can just do better in how we collect information linking physical growth and nutritional status to health.
Great. Thanks very much, Dr. Stevenson. That's great. Oh, Bauer. Do you want to do you want to stop share screen so we can just have maximize people's faces if they have questions? So I want to open up to Q&A, and you can either raise your hand. If no one's speaking, you can unmute and ask a question, or you can type a question into chat if you prefer that, and we'll try to get those answered. And I don't know, Dr. Stevenson, if you want to start out with like what you had a lot of questions, but here's a question from Lorna Padanella. Are the CP growth charts available through Epic to utilize clinically?
Well, that's a great question, and they are available at some institutions. For example, I know that they're available at Nationwide. They're not available at my institution yet. I'm trying to get them into our Epic because every institution's version of Epic is a little bit different. And then some institutions have Cerner, but I think that's a great question, because without those CP growth charts in the EMR, in the medical record, they're not going to get utilized. And I think that's key. I was just visiting Kennedy Krieger at Johns Hopkins, and they just got it into their Epic as well. So it's possible to do it. I'm still working on my team.
Great. And I will say that one of the things that Dr. Stevenson has done is we're taking the data set and trying to push it into the sites so that they will be able to, if they don't have the chart to graph on, they'll at least be able to get the percentile as a function of the weight and the GMFCS.
So Dr. Gaudet commented that sometimes in Epic, the 20th percentile in the CP growth charts is not obvious, is not called out in Epic. So yeah, that's the other part in terms of interpretation, and being able to actually read the growth charts accurately.
So one question I would just, I don't see another question, I'm gonna, one of the things that came up in our annual meeting planning today, I thought was an interesting question. How big of an issue do you feel like nutrition is as a transition issue for, patients 14 to 18 as they transition out of care? I don't know if you have enough exposure to those kids that transition to feel like you have a sense of that, but do you feel like that's a critical issue in that population?
What do you mean a critical issue?
Well, so, we were talking about the importance of well-being overall in the meeting today, of people taking responsibility for it. Do you have a sense as to whether or not the nutrition as an element of that, is that something that, like, I don't know if you have a transition clinic, do you, like, is this an area that you work on from a transition perspective in a transition clinic? That's multiple questions wrapped in there.
It is. There aren't any great guidelines in terms of trying to define what is a healthy weight for somebody with any specific level of impairment in terms of GMFCS level, or however you want to grade it. We certainly can't use information from the typical population. So one of the things I do as kids stop growing as teenagers and young adults, is to try to come up with a target weight for them that's specific to them. And this is not, I made this up, this is not data based, but I feel like I'd find a weight at which their growth chart shows that their body fat is lean. So I actually measure the skin folds, and I try to get kids and young adults to have skin folds somewhere between the 20th to 25th percentile if possible, certainly below the 50th percentile. And then I tell them, okay, this is your target weight. We want you to try to keep close to this weight over the years. I think families have liked that, to have that target weight to have in mind is something that we want to try to shoot for and try to keep them near that level. BMI isn't very helpful in this group of individuals. And one of the things I worry about, and has been shown in adults with CP, is that there is a greater than typical risk of being overweight. And one of the questions here is, my 35-year-old son was recently diagnosed with very high LDL levels. He has ALS, so a severe neurological condition. And I think the same issue is seen in an individual with CP sometimes, is that they do have these increased cardiovascular risk factors, high LDL, related to being overweight. And sometimes I feel like the medical system shares a little bit of blame there by often during childhood sort of pushing nutrition, because the kids aren't as high as they should be on the typical growth charts. And maybe we'd do a better job if we use the CP growth charts to at least try to normalize expected growth.
Interesting. Well, thank you for that. And you addressed that question. So next I'll go to Duncan, and then I'll come back to the question from Katie's iPhone.
Dr. Stevenson, either in Australia or your work here in the States, I see where NIH has recently agreed to identify cerebral palsy as a health disparity. And I would assume if there is a health disparity, there may also be a nutrition disparity with our population. And I'm curious as to your studies in Australia, how is this growth and weight related to caloric intake, and what is the quality of that caloric intake, i.e. protein versus carbohydrates versus fat?
Yeah, that's a great question. I don't know that I haven't seen a lot of work on the quality of diet, in terms of what's the best diet in terms of, percentage of proteins, calories, fats, those sorts of things, if that's what you're asking. So I don't have a good answer for that. I don't know if my colleagues here want to take that on, Dr. Gaudet. If there's anything you know about that. A lot of the studies have been in people who are tube fed, and their diet is quite different. So you can't really judge that.
Right. I don't think there are any clear data. We have used milk-based formulas for a long period of time. They seem to do okay as best as we can tell. There has been a push towards food-based formulas, at least in the tube-fed population. We know that from a gastrointestinal symptom perspective, kids seem to do better, but don't understand how it affects overall nutrition status and body composition and other outcomes.
So the best I can say, the best is just a varied diet seems to make a difference, so not too much of one food. So some balance of whatever is culturally appropriate, fats, carbohydrates, vegetables, fruits. In general, that's what dietitians around the world tend to recommend. And then for the tube fed is the one it's probably studied the most, and there's really across the world more interest in rather than giving the milk-based formulas that we've used for a long time, is just put regular food in the blender and give more food-based liquid diet.
Interesting.
Thank you.
Other questions? Dr. Stevenson, do you have any questions that you want to target at the group specifically?
Yeah, I'm interested, in terms of what should we be measuring in terms of an outcome measure? Sometimes I particularly thinking about the ones and twos. I see a lot of children who are ones and twos who very often, when they're young, they are quite thin, and they often talk about fatigue, or their families talk about fatigue, and wondering if that's something that's been in other people's experience, if that's something, not sure how best to measure fatigue, but that's another question. But because ideally we'd give enough nutrition for kids to have energy to get through the day, right? And that's what I mean by needing other ideas of things that we might highlight as a link between nutrition and some kind of functional activity, or nutrition and some way of measuring health or quality of life, or just being able to participate in daily activities. What are your thoughts about that, either for children or young adults?
I'm personally looking at the promise measures for fatigue to see if I think they would apply at all. But I don't know if you've looked at those.
I have. There are some there. I actually am on the PhD committee for a student at Virginia Tech, and she's going to be looking at this question and just a small number of kids, but as a proof of concept, and see if we can measure fatigue.
If you just measured it amongst the, I mean, I assume that one of the good things about promise measures is there's a fairly large N of answers across the typical population. If you just measured this across, the challenge is, I don't know if this is a pediatric, it's for use in an outcome in RA. But I'd be curious if you would be able to get something just to get what is that same kind of relative comparison as you're getting on the growth charts. What's the level of fatigue in given populations based on GMFCS relative to their typically developing peers? Yeah.
So for those who aren't aware of PROMIS, PROMIS stands for patient-reported outcome measures, and NIH has developed a whole list of different questionnaires that we can use for research studies. Katie comments that my son complains of fatigue and all over pain almost daily at 8 years of age, often has to sit down frequently during playing. Yeah, that's the kind of the thing that I mean. How is there a way that nutrition could help him, or find some other way to help? Lorna asks whether your 1s and 2s wear any orthotics. I find even SMOs improve endurance in some patients. Yeah, certainly a lot of our patients wear orthotics who are, especially the level 2s, but even the 1s when they're young, and then they become teenagers and refuse to wear them. But it is true that those can improve stability and endurance for some. Many people with CP are on medications that cause fatigue, so I think the data would be skewed. That's a fair point. There are always comorbidities that kind of make it hard to interpret things sometimes. So there's lots of things that can cause fatigue, not just nutrition and not just having to keep up. I mean, the problems with kids who are level 1s and 2s is that in order for them to keep up with their peers, which they want to do, they actually have to work harder than the average kid. So they actually have to be more fit than the average kid. And so they almost have to be like endurance athletes in a sense, in terms of their nutrition and overall level of training. Katie says, yes, we wear AFO on the affected side. Maybe we could measure endurance with a 6-minute walk. Yeah, and I think we could, I agree. That's a good way that's a standard way to time that. I think we can also measure how much kids walk out in the community, using accelerometers or, smartwatches.
Yeah, I know Christy Bjornson's done a lot of work with that stepwatch to measure that.
Ginny Butler comments, I'm 50 and feel fatigued even more so. And I've certainly, as I've met older individuals, adults with CP, that is a common complaint, no doubt.
Dr. Stevenson, I think we've kind of timed out, and I want to be respectful of the time, especially on the East Coast and your time. So let me say thank you very much for an informative presentation. Thanks for taking the time to do the Q&A, and thanks everyone for attending. We will put the recording up on YouTube tomorrow. I know I got some mail from some people who had trouble with the link, so people will be able to record it. But thank you very much. Look forward to a follow-up when we've gotten some of this data that we're trying to get through CPRN and when Dr. Murari has her presentation. So thank you all.
Thanks, Paul.